So basically, the short answer is that we have made progress, probably more compared to other conditions in child neuropsychiatry in terms of autism spectrum disorder, in terms of the impact of genetics in clinical practice. But I think it's fair to say that currently we are not there yet at all, and so there are no direct implications in terms of personalized care. So this is the short answer. So let me just elaborate more on that. So basically, we know that the first point I think is important to highlight is that we know genetics for autism spectrum disorder is not there for the diagnosis. So you don't do or confirm or disconfirm the diagnosis based on genetics. The diagnosis is still based on a clinical assessment. What we hope with genetic assessment is to, in a way, gain more detail on the clinical phenotype to identify more specific phenotypes, subgroups, and characteristics of specific patients that will allow us to go towards personalized medicine in terms of diagnosis and treatment. So first point I think is important. I think nobody would endorse currently the use of genetic for the diagnosis, but there is a lot of excitement and research about its possible use to introduce personalized precision medicine. Now, looking at what happens currently, the reason why I said that we have made quite good progress compared to other conditions is that if we look currently at how genetic is used in clinic, there are mainly two levels. So the first level, so the first tier, where we can, many healthcare providers, of course, it depends on the specific country and specific provider, but in general, where it is affordable, the first level is to use what we call array-based genetics as a first tier, and this includes either single nucleotide polymorphism, so SNP, or comparative genomic hybridization, CGH, as a first step to detect important genetic differences. Then, as a second tier, many healthcare systems are able to provide what we call the whole exome-based sequencing, so WES, which some care provider can afford as a second level. In addition, I think historically we have done this quite a lot, and it's still valuable to do karyotype and Fragile X texting. And if the clinical assessment, so the clinical phenotype suggests specific dysmorphism, so specific possible syndromes, we do also more specific approaches. Now, if we do this approach, so first level, second level, what the diagnostic yield, what we call, which means how many patients are we able to characterize, how many times, which percentage we find genetic result, we are around, let's say, 8% with the first level, and we go up to 15% with the second level. But when there is a comorbid intellectual disability, we go up to 37% roughly. So these are quite high numbers. If we look, for instance, the use of neuroimaging, the numbers are lower. So currently with the genetics, we are able to identify to characterize a sizable portion of individuals with autism. And that's good. That's a good achievement in the field. As I said, it's not the case for other disorders or for other diagnostic modalities. So this seems quite good news for the field. The bad news, so to speak, is that actually once we detect these genetic abnormalities, this is still yet not translated in specific clinical approaches. So ideally, I would like to say, okay, I have identified this specific difference. And so based on that, we can use this targeted treatment, for instance. And unfortunately, we are not there yet. This is still important because it's important for parents, families, and individuals themselves to know that there is a genetic abnormalities. It removes a lot of stigma and self-blaming, but we are not there yet in terms of translation. And obstacles are the fact that there are mosaicism, epigenetic alteration, polygenetic risk scores are, quite on fashion, but they are not applicable to clinical practice yet. So all in all, I would say to summarize, and I know I provided a long answer, but it's quite complicated. And we need to go on integrating not only genetics, but also looking at transdiagnostic modalities. So what do these genetic alterations lead to in terms of pathophysiology and so on and so forth. So all in all, there's been a lot of research. We have advanced quite significantly, but we are not there yet. I think to answer this one, probably I would like to bring more my experience as a practicing clinician. And I think interestingly, I have been working in different healthcare systems, Italy, France, United States to some extent, and United Kingdom now, which allowed me to have a kind of perspective on how different services work in terms of really diagnostic pathways and workup. So I would say that probably how can we integrate this? I think that what I'm observing in some services, certainly at least in the UK, is that clinical services are very fragmented. So a specific disorder is taken care by a specific service, another disorder is managed by another service, and within the same disorder or condition, there are different services sometimes. And this is typically currently in many places, in the UK at least, what happens with autism spectrum disorder. So in some services, it is diagnosed by pediatricians, but then these children go to child adolescent mental health services if they have comorbidities. So this fragmentation, I think, of care is not good, of course, for the patient themselves, for the families, but also for us as a professionals, because if a professional, a colleague is in charge of the genetic assessment, then sometimes the results are not transmitted and they don't reach the other providers. So I think that to me, to answer your question, probably the most important action to make sure that these findings are translated and inform clinical practice is really to make sure that we have more cohesive services rather than fragmented and care in silos, which is what we unfortunately observing. And this is as a matter of commissioning, and so policymakers and commissioners who are in charge of thinking and designing these services. So I guess that this is important because it moves the discussion from the research and theoretical point of view to the political and organizational point of view ultimately. So yeah, we move to another condition, which is in part related, of course, to autism now, ADHD, which I would say is my main area of expertise. So I'm very happy to answer this question because actually the bulk of the research I'm conducting now, funded by the National Institute of Health Research, mainly in the UK, is exactly on this topic. So we talk a lot about precision medicine, stratified medicine, and personalized medicine. And this, of course, has been inspired by other fields of medicine, in particular oncology, to some extent also cardiology, where things seem more advanced in terms of individualizing the treatment. This happens, for instance, with some type of breast cancer, for instance. So those of us who do research in the field of child adolescent mental health have been inspired by this, and one day we would like to get there. And this is quite important also for ADHD, for instance, because in general, we have a very good treatments. Stimulants in particular have been there for decades. Generally, they work pretty well, but we know that some individuals respond better to some treatment and others respond better to other treatments. And right now, currently in the clinical practice, this is quite frustrating because basically we find the right medication based on a trial and error process. If we are lucky, so to speak, we find the right medication immediately, but if not, it can take months. And this, of course, is a huge problem for healthcare systems which are already overwhelmed and stretched. Now, so the question will be, can we go to a precision medicine also in our field, and not only in oncology and so on and so forth? So I think that, of course, there are several issues that I would like to highlight. I would like to highlight three ones. So the first is that, of course, I think that if we stick to the current diagnostic categories, we will never get there, because the current diagnostic categories we use in mental health based on DSM approach or ICD are descriptive, are a cluster of symptoms that are very helpful to enhance and standardize the communication among clinicians. So if I say I saw a child with ADHD according to DSM-5 criteria, my colleague knows what I mean, but they have not built on a neurobiological basis. So we know that the underlying neurobiology is extremely heterogeneous. So the first thing is, if we keep on sticking to the current diagnostic system, it will be difficult, virtually impossible, to find any biomarker with a high sensitivity, specificity, good positive predictive value, negative predictive value, for the simple reason that we are talking about entities which are not homogeneous per se. The second consideration is that some colleagues are very pessimistic in terms of getting there, in terms of precision medicine, stratifying the patients, because they say we have been trying to do this for decades, we have never found anything. That's true, but also it may have to do also with the methods, how you try to find predictors, for instance, of response. Now, many have relied on individual trials, for instance, the analysis of trials. This is problematic because individual trials, when we test the efficacy and the tolerability of a medication, for instance, are not powered statistically to find predictors. It has been calculated that we need at least 4 times a sample size of a standard trial to get insight into possible predictors of response. So one way to, of course, overcome this is to use evidence synthesis approach, whereby we pull together different studies. And this is actually what I'm doing now. I'm currently funded by what is called in the UK NHR Research Professorship by the National Institute of Healthcare and Research, which generously gave me a large funding for 5 years to develop a program to study exactly the stratification, personalization of medications for ADHD based on clinical predictors, because right now it's very premature and difficult to implement any neurobiological genetic predictors in daily clinical practice. So the question is, based on the profile of the patient, comorbidity, sex, gender, age, and so on and so forth, can we stratify better? So to say, given your profile, this medication may be better than this other. I don't know if you have a specific comorbidity. I don't know, ADHD plus anxiety. What is the best medication in general based on studies? The third aspect that I would like to highlight in this regard is that when we think of personalized medicine, we generally think of, genes, molecules, physiological mechanisms. There is also what we call the exposome, so the environment around the patient, and also importantly the patient's preferences, which are linked also to possible expectation effect, placebo effects. This usually is not well studied. It's not something people talk a lot about, but we do know that expectation effect do have a huge impact ultimately on the response. So I think that researchers should focus also on these, the personal preferences and the expectation of the patients, to integrate these in models of precision psychiatry. So far, we have tried to, in a kind of naive way, I think, try to see if that specific gene could predict the response to treatment, but we know that, of course, the picture is much more complex than a few genes. So I would like to see a more holistic approach also in terms of precision psychiatry in ADHD and in general in other disorders. Yeah, I think autism spectrum disorder associated with rare syndromes, of course, is a focus of interest for the journal, clearly, but is also very important in clinical practice. And I think the question you ask is very relevant. I mean, there will be many aspects to highlight, but once again, in the interest of time, I would like to focus on a two or three ones. So the first is that I think is important to align preclinical and clinical endpoints. What we see that when we look at a preclinical literature, animal models, of course, these preclinical studies often measure molecular or kind of other outcomes that synaptic outcomes, while clinical trials, of course, in humans tend to focus on behavioral scales, rating scales, and this creates really a kind of translational gap. So the lesson we can learn and how to improve is probably to identify kind of biomarker, what we call intermediate phenotypes that are quantifiable both in animals and humans. So I think that is very important to bridge this gap between the preclinical and clinical. The second thing, and this is particularly a problem with rare condition, of course, since by definition they are rare, it's hard to recruit participants in trials. And, a small sample size, of course, are not good because means that we are not powered to detect important effects. So fortunately, I think recently there have been some developments in the methodology of trials, like what we call the adaptive trial design, for instance, sequential trial, really can maximize in a way what we can learn with fewer participants than a usual trial. We also know that, for instance, also other design, the crossover design, which has some problem, but it can decrease the between subject variability. So once again, important advantage in terms of power. But ultimately, we say that to overcome this issue, probably the best approach is really around building international consortia, so sharing data, not only at the national level, but also at the international level, and in the spirit then of open science, then share this data for the scientific community. And the last aspect I wanted to highlight is really around the timing of the intervention, because when we talk about autism within the framework of rare syndrome, we need to consider that, of course, these syndromes involve usually early neurodevelopmental disruption. But trials often come later, so they test the effect of medication later on in the development. So, it's quite hard to detect an effect when it's a bit too late. So I think that we need to consider trials usually in younger cohorts. This poses, of course, ethical issues, but they need to be discussed with ethical committees and in terms of scientific community, raise awareness about this. Because, we need to be aware that there may be windows in the development that are critical for the intervention. And if we do something which is after those windows, we may have a failed trial and so spend a lot of money, time, resources, and energies for nothing, basically. So I think all these considerations are very important when it comes to these kind of trials in this specific population. I think in terms of strengthening the quality of research, what strikes me is that, of course, there are different study designs and there are a different level of the hierarchy of levels of evidence. So, of course, we know that currently what really is impactful in terms of informing clinical practice and future research is evidence synthesis research rather than primary studies. Of course, we need good primary studies, but we need especially also research which pull together these studies in a meaningful way, in an accurate and really high-level way. So we know that we can put together results of the studies in meta-analysis or umbrella reviews, which are basically systematic review of meta-analysis. So I think that what I would like to see more in the future from the journal is really this kind of evidence synthesis pieces that really can inform clinical practice and policymakers with a strong evidence. Oftentimes, we read reviews, narrative reviews, or even systematic reviews, but unfortunately, these are not good enough. So narrative reviews are good to discuss possible trends for the future, but certainly they cannot inform as to whether specific treatment is effective or not, for instance. So we really need a quantitative evidence synthesis which relies on primary studies, to ultimately increase the power, the statistical power of primary studies. We know that if we take 10 studies on the same treatment, we may have 4 negative, 6 positive. So what we conclude, should we conclude that the medication work? Not necessary, because if the 6 positive studies are of bad quality, we need to rely more on the negative trials, which are of better quality. So the only way to get around this is meta-analysis. Meta-analysis have a huge problem, however, that they provide information on the group level. So in general, this is not applicable to the individual patient, and clinicians want information applicable to the individual patient. Meta-analysis may tell us, the effect size of a medication is 0.8, but this can be 0.5 in one patient and 1.3 in another. So we really need to move ahead with a more sophisticated approach of evidence synthesis, like individual participant data meta-analysis, and so on and so forth. So I think really it's important to look at the high level of evidence. The other, and you asked those about international dissemination, I think probably 2 considerations spring to mind. So the first is, I'm aware of some journals that are translated in different languages, and this, of course, increases the dissemination of the articles. So I think this is a good strategy. The second, I would say, we really need to get to not only a highly selected group of readers, researchers in the field who are very knowledgeable about these disorders, but also to general clinicians, and importantly, also people with lived experience of the disorders. So I think that it's good to have a kind of sophisticated papers, but we need also some kind of digest format to digest really this information for the big public or the clinicians who are not extremely knowledgeable about the topic. And importantly, I think is really crucial nowadays to involve people with lived experience, not only in the last phase of research, which is dissemination, but also in co-designing research. So I think that also seeing papers in the future in the journal co-designed by people with lived experience with these rare conditions will be extremely impactful in terms of their really value for the clinic and for the research field. So I think, these are some kind of suggestions that I think may simply be considered to enhance the value of the journal.